Thank you, WIROC Global. Thank you, North Zone, the President, Secretary, Dr. Harpal, everyone for giving this wonderful opportunity to be sitting at my home and learning academics with all the experts out there. I will be discussing something which is quite rare, not very common, which is a tibial plateau non-unions. If you look at the literature, it is less than 3% of all the fractures. If you look at Sarmenteo's paper, which he treated conservatively proximal tibia fractures, the non-union rate was less than 3%. So if it is more by our surgical techniques, it's all our fault. Why does the non-union be so rare? It's because of the large cancellous bone which is there, which is opposed to each other, which does not allow the non-unions to happen. And there is an abundant blood supply with a lot of muscles posteriorly, popliteal, and all the other things lying just next to it. But it's the neglect in our part of the world, the faulty surgical techniques that we use, and the bone loss, which was just discussed by Dr. Kale, as well as the infective by the previous speaker, that causes the non-unions. Our goals in the proximal tibia remain the same. If it is an articular one, we'll try to restore the articular surface. The most important thing to do is the limb alignment. That's the most critical thing by what we are doing for the proximal tibia and as for the distal tibia as well. And to facilitate a proper functional knee recovery. What are the managements? It's basically dependent on the diamond concept, which we all remember and know now popularized by Peter Giannodis. We debride the non-union site, try to correct the deformities which are there. That's the thing which is different from the rest of the non-unions which you're going to see. That we need to correct the coronal and sagittal deformities, use the bone grafts as was shown before, and have good fixation and stability provided by plates or nails or whatever we are using, or by Ilizaro and biology to be also maintained for the diamond concept. If you look at the literature, there's only few papers for the proximal tibia, and mostly of them are for extra-articular malunions or non-unions. And the things which Dr. Wu from Taiwan has used in 2006 in 28 patients has been an angle blade plate, the old, our own angle blade plate, which we have been using so often in all the other places. From the medial side, going anteromedial to the posterolateral area, and there they have been able to fix it and get the compression with the articulating tension device and getting the bone grafts to ensure that the PMTA or our angle is not in varus, and the angle acceptance level has been 5 degree of varus maximum and 10 degree of valgus. So in these cases which were not properly treated and were either mal or non-united, they have been able to use the angle blade plates and get good reduction. Remember, the deformities which we are going to see and which we have to accept will be less than 5 degrees of varus and 10 degrees of valgus. There's also a paper by Michael Gardner and David Helfet and Lorich. They have seen around 16 patients. This is mostly in the interlocked nail, which was previously done through the different nails as well as the infrapatellar regions, where again they have used the same principle. And if the bone is not lost, you can add a lag screw also to get direct fixations. These are our own cases, non-unions, which come normally due to neglect, I would say. They are not clinically non-unions that 6 months to 1 year have passed by, but at least 2 to 3 months have passed by and still they have not united. So I'm considering them as non-union, as they are very rare. And here also what we need to look for is the alignment part, where we have given them adequate stability, alignment, trying to maintain the posterior slope of the thing and getting a mild valgus. If the bones are in opposition to each other, we give them compression and fibular strut is given as required. And this is what the 6 months follow-up can be seen with good results and having good range of motion. This was a case which was operated elsewhere. You can see a simple extra-articular proximal tibia fracture treated in a different way, or you can say a unique way, with the skin and with the plate pointing and jutting outward, again leading to a non-union when he came to me around 6 months to 5 months later, when he was having, and we got the CT scan done to see that there was a non-union extra-articular, and the same thing was done. So what you do is you take a laminar shredder, which is very important, try to recreate the fracture if it is possible, as we have done here, and then try to correct the deformities both in the sagittal as well as in the coronal planes. Here we had to osteotomize the fibula and then only we were able to get the correction once the osteotomy was done. And we put and use that fibular strut again to put it into the medial side, which is the compressive side, and the tension is not there, and to make sure that our alignment is okay. This is the post-op results. And this is just 4 months. He came to me in January, and he can walk, and he has got good range of motion, as was there previously. But if you look at the alignment has been restored, which makes it very happy. This again is a case. In India, you will find mostly they are neglected, or they come late to us, or with faulty surgical techniques. The classical non-unions are rare with good techniques. Here, this patient was operated somewhere. They had put in a long plate for a proximal third femur shaft fracture, and they just used, because of the combination, an external fixator for this. He came to me around 3 months later because he had some general other conditions, and you can see what they had done for a simple shaft femur fracture also, but that's another story for another day. What we did was we removed the fixator after some time when his general condition was okay, so that we gave him a pin-free period. And then again, the same principles were followed: rigid fixation, good fixation. The gaps were filled with the fibular strut, an autograft which was taken, and the cancellous graft, trying to maintain the posterior slope as well as the coronal slope. And then, as you can see, over the period, even the fibula as well as the other things have been uniting. And then we converted the proximal part, which was infected later, into a masculae, and had to do that. If you look at the intra-articular fractures, if you look at that, they are very rare. Intra-articular fractures, because of the cancellous bone, are very rare in proximal tibia. Classical non-union, where there's no further potential for it not to unite. If this paper, again by Michael Gardner, and they will help it, they have published both extra-articular and intra-articular, and this is one of the biggest papers which you will find in the world literature. They only had 5 cases of non-union for the intra-articular part, where they have done the classical procedure of open reduction, deformity correction, internal fixation with graft, and more importantly, since it was involving the joint, here you need to give arthrolysis as well. You might have to release the intra-articular fragments or the adhesions which are there, or have something to do for the extra-articular. All of them united. However, remember that in their cases, they had some arthrosis which developed. So we should be aware of arthrosis which might develop. The challenges in the intra-articular are the small articular fragments. Because they are very small, they become very poor in bone quality. Osteoporosis happens very fast when they are immobile, or let's say they are not giving weight onto that leg. Soft tissue attachments have to be removed, and that makes it more avascular. And the scarring which is there, especially on the posteromedial side, is going to be causing a lot of difficulty in getting the deformities to be corrected. This is our case in which was done in our own unit. A 67-year-old lady having a fracture, a mother of a surgeon who had some issues, and this you can see that there was some varus deformity, and it was having a lot of pain around 6 months. We tried to see it under image, and we could see that it was getting slightly corrected with some amount of gap out there. You need to understand in a CT properly where exactly the intra-articular fracture is going. Try to recreate that if you can do it with a big amount and good amount of bone, which is there intra-articular, and then you try to lift it up. Usage of laminar spreader out here is very important. And once you use it, get it in adequate size, just like you do for your proximal osteotomies of the tibia. You put in a wedge graft if you can, and then try to fix it with a plate. That's the thing. Another case with a posteromedial fracture, which was again reduced with some amount of adhesions and was fixed. I just have around 1 minute, so I'll finish off this case. A young case, 23-year-old patient. Here, when we were trying to do a laminar spreader, if you see the intra-articular fragment broke because it was having a very poor bone. And then we had to put in the K-wires to hold it. And then with the help of clamps, we were able to reduce it and get this fixation. So take home from my side is use the diamond concept of mechanical stability and biological activity. Use of bone grafts with fixation is important. The key out here is the normal alignment of the knee along with both the posterior slope and the coronal plane. Proper counseling, especially for intra-articular, because arthrolysis or knee stiffness can be there. Thank you very much for your hearing.